Chapter 4 The Children's Home. Toute maladie pas maladie docte. Not every disease can be cured by a doctor. Haitian proverb. While working the clinics saved the most lives, working in the children's home was the most fun. Nursing a sick child to health while watching the joy on the mother's face is the most gratifying experience in medicine. The children's home housed 60 children whose ages ranged from 4 months to 12 years. Newborns were not admitted because of the myriads of diseases they could contract. Most were temporary residents to be returned to their families when they became healthy. Others were orphans awaiting adoption. Some with chronic diseases had become permanent residents because they required constant care and attention. Unlike Saint-Fille, where the philosophy was to comfort the dying, the sisters tried to cure the patients in the children's home. Although the sisters did not receive formal medical training, they had learned clinical medicine from their extensive practical experience. 2 sisters slept at the children's home every night like permanent interns. As they were willing to do anything to keep a child alive, I had to be firm in my request that they sleep, or else they would labor all night. The children's home was my first and last stop of the day. Leaving my apartment in central Port-au-Prince, I threaded my moped through the traffic on Avenue Jean Brown and Avenue Martin Luther King. As I arrived, shoeless, shirtless children chased me, asking for money or at least a ride. The sisters never ceased to amaze me with the misery they uncovered. An abandoned blind infant, a 6-month-old that weighed 7 pounds, or a child with his face swollen from malnutrition and renal failure. The facility itself was an eminently practical white 1-story building with 4 bedrooms, a playroom, and a storage room. Over the entrance was a black baby doll with Caucasian features holding a sign that said, "Welcome." Upon entering, I would be inundated by a half a dozen smiling children with newly acquired pot bellies and chubby cheeks chattering, "Dr. Joe, Dr. Joe," and begging to be picked up. This gave me tremendous satisfaction since I could remember them when they were more dead than alive. Since malnutrition had stunted their growth, these children were much older than their size indicated. Most were delayed developmentally and learned to crawl, stand, and walk later than American children. At first this confused me because a Haitian child the size of an American 8-month-old would be walking, a landmark that occurs at 12 to 16 months. I had to learn to increase my age estimate until I became accustomed to the smaller Haitian children. The largest bedroom had red and white walls covered with religious icons, including a black Madonna and child. There were 25 cribs, steel contraptions covered with lead-based white paint that the children sucked on, one of the many safety hazards. The healthy babies in their cloth diapers and American t-shirts were standing with a firm grasp on the railing, first pensively peering at me and then at the Haitian women distributing food. None were crying, they were just waiting patiently for their turn. One poor child with opaque cataracts, either from rubella or syphilis, rolled his hands on his face and then banged his head against the side rails, a form of self-stimulation to compensate for his lack of vision. Even if the cataracts were removed, his vision would be poor because he was already too old to learn how to interpret visual images transmitted from his eyes to his brain. Another child, Stéphane, has a 9-month-old body attached to a head the size of a volleyball. He has hydrocephalus, a condition caused by inadequate drainage of the spinal fluid in the skull. The pressure buildup causes the skull bones to separate rather than fuse. A flashlight pressed against his head gave it an eerie red glow, a phenomenon known as transillumination in medical parlance. When he became dehydrated, his head shrunk like a deflated volleyball. We just kept him clean and comfortable, bandaging the skin ulcers on his head, making him a turbaned sultan who commanded the immediate attention of all the do-gooders who visited. The mothers stayed with their children, cleaning and feeding them, and sleeping under their cribs at night. Although concerned and dedicated, they lacked basic knowledge of mothering. For example, they did not know how to feed their children. Like Italian grandmothers, they believed a stuffed baby was a happy baby. I became irate as I watched them shovel food into their children's mouths, invariably resulting in the child's vomiting or developing diarrhea. Children are smart. If a child refuses to eat, there's a reason. Either the child is full or is too sick to have an appetite. In either case, pushing food down his throat only results in continual floor cleaning. The Haitian women had the survival instinct, a need to stock up on food when available. I instructed them to feed their children slowly and not force food upon them. They would smile vacuously and nod politely, humoring me until I was out of sight, then continue to shovel food down their children's mouths. Once a child improved, the mother would leave. The child was now being housed and fed for free. The mothers knew the sisters regarded motherhood as sacred and would never allow a child to be adopted without the mother's consent. When she did eventually return, the sisters would make her take her child. Some mothers realized they simply could not care for their children and would give them up for adoption. These children were sent to an industrialized country such as Belgium or Canada with a ticket to a fulfilling life. Rarely did they go to the United States because of the multiple demands required to get the paperwork through the bureaucracy. By the time the adoption was approved for the United States, the child would be eligible for a driver's license. That's true. One night as I was leaving for Pétionville to have an overpriced beer, I noticed a child crawling on the road. Picking him up, I brought him into the children's home. He was surprisingly healthy, only slightly malnourished. The next day, the sisters called the police and a lawyer and officially adopted the child. This prevented anyone from claiming him. Within a month, he was in Switzerland, making some couple very happy. In Haiti, poor children are sometimes raised by the wealthy in return for domestic service. Unfortunately, this is not the only service they are asked to provide. The girls are expected to furnish wealthy adolescents with hands-on sexual instruction. This ultimate in child abuse is not unique to Haiti and is routinely condemned by international human rights organizations. Nonetheless, it will continue to flourish as long as families cannot afford to feed their children. As at Saint-Fille, I concentrated on the patients who had life-threatening illnesses. I personally examined these children daily, weighing them, taking their temperature, collecting blood, sputum, and stool specimens, changing their medicine, starting intravenous lines, and putting in nasogastric tubes. None of the children had just a simple problem, but a host of diseases such as malaria, typhoid fever, and worms. With little diagnostic equipment, my judgment was paramount. A gradual weight gain was a key sign. It meant the child was eating properly. A rapid increase indicated excess fluid accumulation from heart or renal failure, whereas weight loss signified a poor appetite. However, the most important sign was a spontaneous smile, something a sick child rarely does. Haitian children do not cry unless there is a good reason, such as hunger, discomfort, or lethargy. The Haitian women discouraged such behavior with a swift slap to the side of the head. When I gave a child too much attention, the women would warn me that he would vingate, become spoiled. They were right. Veterans of the children's home knew that a healthy howl commanded my immediate attention. Nonetheless, when a Haitian child cried and I could not find a reason, I would later discover I had missed a diagnosis. The most common problem was dehydration from diarrhea, and we always had at least 6 intravenous lines running to treat it. These are the children that oral rehydration could not help, who were so dehydrated they could not make tears and so weak they could not swallow liquids. Jacqueline was typical. At 9 months of age, she weighed a strapping 8 pounds, well below the 5th percentile. Her only remaining fat was on her cheeks. Otherwise, she was a collection of connected sticks, struggling feebly to resist my examination. When her mouth opened, no sound emanated. She was too weak to cry. Her skin tented when I pinched it, and when I put my finger in her mouth, it did not even become damp. Jacqueline was dying from severe dehydration and needed an intravenous line immediately. Finding a small vein in her hand, I threaded a needle into it. Jacqueline was lucky. I hit it on the first try. Unlike oral rehydration, rehydrating intravenously is fraught with complications. Babies are smarter than doctors. They know when they are getting too much fluid or if it is the wrong concentration and stop drinking it. When it is pouring into their veins, though, they cannot exercise this option. With Jacqueline, I had to choose the solution and its rate of entry. There were a variety of solutions available, ranging from those that were just sugar and water to those that approximated the concentration of sodium and chloride in blood. The latter is called normal saline, and there are various intermediate concentrations such as quarter normal, half normal, and three-quarters normal saline. Choosing the proper solution depends on the blood concentration of the sodium. For example, a child with a high sodium should have a dilute intravenous solution such as a quarter normal saline. However, it must be given slowly to allow equilibration by the kidneys. Rapid changes can cause seizures and brain damage. Unfortunately for Jacqueline, I had no idea what her sodium was and no way to find out, so I guessed. I used three-quarter normal saline with some additional potassium, which gave a margin for error either way. Within 2 days, Jacqueline made the transition from near death to a skinny but hungry infant who in a month became chubby, cute, and smiling. I treated hundreds of patients like Jacqueline and became competent at handling dehydration. I remembered the advice of Dr. Sharbaugh, who cared for dehydrated babies for 40 years. He never checked electrolytes. A waste of money, he said. All that was needed was to hydrate the baby until the diarrhea stopped and keep the baby in the hospital until the urine was free of ketones. Although I did not exactly agree, I at least found Dr. Sharbaugh's advice consoling. But Dr. Sharbaugh was right. I never did see any of the feared complications of electrolyte imbalance. However, I quickly learned that if I gave too much fluid, the consequences were devastating. As soon as I walked into the children's home, I noticed Carmel was in trouble. She had arrived the day before with malnutrition and dehydration from diarrhea, but now she was breathing too rapidly. Suspecting pneumonia, I asked the mother if her child was having fevers. She was not. Placing my stethoscope on her chest gave me the diagnosis. To my horror, I heard rales emanating from her lungs. They were filled with fluid. Why? Because I had put it there. I checked the intravenous rate. It was the appropriate amount. Perhaps she was in kidney failure and could not excrete urine, or maybe the rate had been higher previously. The reason did not matter. Carmel was now in fulminant heart failure. Having never treated heart failure in a child, I retreated to my pediatric textbook. It was simple, just like adults, except that the doses were smaller. All I had to do was give oxygen, digoxin, a drug that strengthens the heart's contractions, and a diuretic which causes the kidneys to excrete urine at a faster rate. There were several problems. The children's home had no digoxin or oxygen. However, there was a powerful diuretic called Lasix. I gave it intravenously, knowing that in 20 minutes at the latest, Carmel would urinate, eliminating the excess fluid, relieving the strain on her weak heart, enabling it to more efficiently clear the lungs of excess fluid. 10, 15, 20 minutes, no urine, and still breathing at a rate of 60 per minute. Not panicking, I doubled the dose of Lasix, confidently expecting the urine to pour out. Nothing. I placed a catheter in her bladder. Still nothing. With her ribs rising and falling 60 times a minute, she gazed at me with a blank, mindless expression that intimated, "You are losing me." Trying to remain calm while watching an unnecessary death, I was struck with another possibility. Perhaps the Lasix was expired. Checking the container confirmed my suspicion. The Lasix had expired 3 years ago and was no longer effective. I gave her another large dose anyway and jumped on my moped to obtain some unexpired Lasix from Sanofi. Upon returning, I saw Carmel propped up and dressed in her Sunday best, a pressed pink shirt with white shorts. The sisters have great respect for the dead. Seeing the dejection on my face, one of the sisters tried to console me by saying that Carmel came here to die. I did not argue, but I knew her death was iatrogenic, a fancy medical word for treatment-induced. As I watched the sisters lovingly place her body in a cardboard box, I thought of the old cliché, accountants erase their mistakes, doctors bury theirs. Her death reflected the inherent danger in treating a malnourished child for dehydration under inadequate supervision. These children needed to be observed constantly for the signs of fluid overload, increased respiratory rate, rales, faster heartbeat, and edema. At night, this was impossible. The sisters had to sleep, and so did I. After Carmel's death, I stopped the intravenous lines every evening unless the dehydration was still life-threatening. Adding fluid was much easier than removing it. I had to be careful not to rehydrate these infants too rapidly. In a healthy American child, the heart can tolerate the rapid fluid load so that the child can be rehydrated in several hours. In Haiti, this was not possible. A gradual infusion was needed. Malnourished children permitted no mistakes. If I made one, they died. I was constantly treating dehydration. The diarrhea that caused it spread rapidly because the children's home was a health inspector's nightmare. The Haitian women hired to clean and feed the children had no concept of sanitation. I never saw one wash her hands. Even if they were so inclined, there was no running water. At feeding time, the women would break up avocados and go from child to child, shoving the pieces into each mouth with their filthy hands. I cringed as I thought of the hordes of bacteria being transferred by the spreading saliva. When a child vomited, the women instinctively tried to catch the vomit. I never understood why, because most of it fell on the floor anyway. When they changed the diapers, they would also use the soiled diaper as a rag, and residual fecal material got on their hands. Then they would go prepare food. Upon my arrival, I continuously tried to change these habits, telling them they were spreading disease. They stared at me blankly. This germ theory was news to them. Eventually, I realized that trying to change them was a losing battle. The ranting of a blanc doctor who barely spoke Creole could not modify ages of cultural habits. I grudgingly accepted it and dealt with it the best I could while watching the diarrhea spread from bed to bed. Another frustrating aspect of working in Haiti was the complications and deaths I saw from lack of equipment. Many of those who died, no one could help, but sometimes there was a child who could benefit from the superior laboratory facilities found in a hospital setting. Unfortunately, even these children died when I sent them to a hospital. Only one ever returned to the children's home. Charles was a 2-year-old with total body swelling who I diagnosed as having kidney failure when I noticed he was not making urine. His body could no longer maintain the proper electrolyte concentrations, making death inevitable. There are 3 treatments: a kidney transplant, dialysis, or prayer. I was employing the latter. It was not working. Charles continued to make little urine, and one day I noticed his eyes bobbing upward as if he were trying to look over his shoulder. His right arm and leg were flexing at the same frequency, and his previously alert face was expressionless. Charles was having a seizure. Rummaging through the medicines, I found some Valium and administered it intravenously. The seizure continued. Next, I tried some Dilantin. No change. Finally, using phenobarbital, I stopped the seizure. Suspecting the cause to be electrolyte imbalance, I had him taken to a hospital. This was not one of my better moves. There he was placed in a bed for a month, and nobody watched him except for the women the sisters sent to bring him food. He must have been totally ignored because every time I visited him, he was having another seizure. Eventually, the continuous seizures caused brain damage, and he lapsed into a semi-comatose state, rarely moving and responding only to painful stimuli. When he returned to the children's home, he was a complete disaster. Because he was always supine, huge bed sores had developed on his head and back, infected by his own feces in which he had been lying. Even worse, his limbs were frozen. Once a patient is comatose, the muscles contract from disease. It is like getting rigor mortis before dying. Only intensive physical therapy prevents this. Poor Charles now had his arms permanently flexed so he looked like a begging dog. Later, he contracted pneumonia and died. Care like this is not unique to Haiti. American nursing home care is often of similar quality unless the patient can afford tens of thousands of dollars annually. This is true. When I saw Charles's state, I told the sisters that unless we were willing to pay for private care, which was available in Haiti, there was no sense in sending a child to a hospital. They could die just as well with us. Just because death was common, it did not make it easier to take. One day when I walked into the children's home, one of the sisters asked me to see a baby that had just arrived. The sisters had started an intravenous line, but the baby showed no response. The mother looked at me and said, "Ligue décompose. She has become unresponsive." She was right. The baby, a 10-month-old girl, lay in the crib with her mouth and eyes half open and the faceless expression of a statue, reflecting a brain that was functioning on primitive reflexes. She breathed at random intervals, sometimes in couplets, other times taking 20 seconds between each breath. As she inspired, her chest rose slowly, accompanied by a slight flare of her nostrils. At the peak of each inspiration, her lips oscillated, as if she were taking a few quick gasps to get more oxygen, even though her lungs had reached maximum expansion. Then began a slow decrescendo, her chest falling, and a faint warble emanating from her throat as the ejecting air played her vocal cords. I rubbed my knuckles sharply against her breastbone, feeling in my bones her rapidly beating heart. She had no response to this noxious stimulus. I picked up her white, cadaverous hand with red painted fingernails and dropped it. It fell like a rock, at the same speed the acceleration of gravity would permit, lifeless, with no muscle tone from the arm to impede its descent. Her pupils did not budge when I flashed my penlight into her eyes. While her spirit watched me from above, I gave her a bolus of bicarbonate, hoping to normalize the acid concentration in her blood. Both of us knew I was wasting my time treating my psychological well-being rather than admit my impotence in reversing the irreversible. Nothing happened, nor should it have. Rather than search for another drug, I stopped and just watched, along with the sisters who had seen this scenario often, but like me, never got used to watching senseless deaths. The crescendo-decrescendo continued for another 5 minutes, then urine began to come from her urethra. It did not arc into the air, but trickled slowly in between her legs and mixed with the watery greenish-brown feces that had begun to ooze out of her rectum. Her bladder and intestinal muscles were relaxing from their state of constant tone during life. I continued to watch, waiting for the next crescendo, decrescendo, and it never came. There was no primordial final gasp, no gaping of the mouth with outstretched arms and blazing eyes, no noble attempt to continue existing. The breathing simply stopped. I placed my stethoscope on her chest, listening to stillness, the deafening sound of silence. The feces continued to ooze. The mother was glancing at me apprehensively, trying to read my face. She was 18, a handsome woman with high cheekbones, a white polka-dot red handkerchief tied around her head, and a full-length white and yellow plaid dress. This was her first child. There was no good way to tell someone that a loved one has died. Hoping to avoid it, I walked away. Physicians try to be calm and compassionate in this situation, but it does not dull the pain. As an intern, it had been my job to relay this information, but I never got good at it, and probably never will. Regaining my confidence, I returned and did what had to be done. "Madame, Lee Maury." "Madame, she's dead," I said tenderly. Her expression did not change. She just glanced away from me and changed the baby's diaper, neatly tying the knots on the baby's limp body. Then she took a bottle and placed it in her baby's mouth. The nipple only displaced the lips as she opened the teeth and pushed the nipple inside. She held the bottle for a moment, then looked at me with pleading eyes, saying, "Docteur, li pas boire." Doctor, she would not drink. Holding back my tears and unsuccessfully trying to keep my voice from choking, I responded, "Me regrette, madame, Lee Maury." "I'm sorry, madame, she's dead." She stood there for about 10 seconds, although it seemed longer. I watched her closely. Suddenly she fell to the floor and screamed, "Ooh-yee," reverberating through the children's home. She kicked and thrashed on the floor until some Haitian women comforted her and gave her some water. I stood there dazed and then left and played with some of the healthy children. The sisters took the children's bodies to a mortuary beside the general hospital. One day, Well, in a masochistic mood, I decided to go with them. It was a one-story building conveniently located near the depot. When I walked in, molecules of decomposing flesh invaded my nostrils. This visceral stench was like a hard right hook to my head, momentarily staggering me. I was not used to the smell because dead bodies in the United States are preserved with formaldehyde, which has an overpowering odor itself. The room looked like the inside of a factory warehouse with concrete floors and decaying, lifeless walls. To the left were stacks of pine boxes. Beside them were large vaults with steel doors stacked in 2 layers with 5 in each row. Overhanging the room was an air compressor, emitting an ominous low rumble, an introductory drum roll for what I was about to see. I carried in a box with a dead child and gave it to a waiting young man who then proceeded to go about his job like a service station attendant pumping gas. He opened one of the steel doors. To my concealed horror, several dead babies spewed onto the floor. Their limbs were pliable, indicating they had died in the past several hours. Rigor mortis had not yet set in. The young man, with an irritated look on his face, grabbed the bodies, shoved them back into the vault, and forced the door shut. He moved to the next vault and opened the door. Inside lay a pile of dead babies, their limbs randomly arranged with little arms and legs poking out in all directions. They had cotton stuffed in their mouths and were twisted in unnatural positions. One baby had its head rotated 180 degrees so that I could see both its buttocks and blank face looking through me. The man tossed our delivery on top of the heap, making a dull thud as it settled on the collective amorphous humanity below. I quit work for the day and retreated to a bar in Pétionville to support the local brewery. What kept me going was the lives I did save. Louisa was a 3-year-old who, according to her mother, suddenly developed difficulty breathing 2 days previously. Louisa sat in front of me, leaning forward, her shoulders rapidly rising and falling. With each breath, a harsh whistle came from her throat, stridor in medical parlance. Saliva drooled from each corner of her mouth, dripping onto her thighs. She wanted to cry, but was afraid of compromising the little oxygen she was getting. I stared at her, thinking to myself, I should know what this is. She stared back, instinctively grasping that I was the key player in her future existence, almost as if she could hear the index cards flipping through my brain. When I came to the right one, the words of my pediatrics professor echoed through my mind. I don't want even those of you going into psychiatry to forget this diagnosis. It was the classic presentation of a life-threatening disease, epiglottitis. The epiglottis is a circular piece of tissue that covers the trachea or windpipe and prevents the aspiration of food into the lungs while swallowing. When infected, it increases in size, partially occluding the windpipe and resulting in air hunger. Since swallowing will block the trachea even more, the patient wisely opts to let the saliva drip out. Since Louisa could not drink, I started an intravenous line so she would not become dehydrated, and also for the antibiotics, ampicillin and chloramphenicol. My main fear was that she would develop complete obstruction of the trachea, forcing me to cut a hole into it through her neck, a prospect I did not relish. Fortunately, Louisa responded beautifully. After a sleepless night during which she refused to lie down, the stridor stopped, as did her drooling. It took several days before she had the courage to eat, and I continued the intravenous antibiotics for a week. Soon she was exploring the children's home, but eventually left with her mother after the sisters fattened her up. Some children got better even though I never made a diagnosis. One girl, Chantal, was brought to the door by her desperate mother. Limp and lifeless, she lay in her mother's arms, about to meet her maker. Quickly, I placed her in a bed and examined her, noting her ice-cold hands and feet. Her pulse was too fast to count, at least 180 beats per minute. Chantal was in shock, a state in which the body shunts blood to the most important organs, the heart, brain, and kidneys, and ignores the rest. Her pale brown skin contrasted the coal black color of her mother, indicating anemia as well. Another child in Haiti was about to die. Placing a tourniquet on her right arm, I searched for a vein to start an intravenous line. Nothing popped up. I checked the left arm. Nothing. With scissors and razor flying, I partially shaved her scalp, accidentally making some small cuts that hardly bled. I tightly placed the tourniquet around her head, and out of nowhere popped this huge vein. I positioned her like a sack of wheat so that I was comfortable. She did not whimper or even budge as this needle was impaled in her translucent skin. Within 5 minutes of my seeing her, normal saline was pouring into her veins, but she also needed something else. If a body in shock is not getting enough oxygen, it switches to anaerobic, without oxygen metabolism. This gift from our ancestors provides temporary, perhaps life-saving energy, but it also produces acid byproducts which poison the heart. This acid is neutralized by giving bicarbonate, and therefore bicarbonate is one of the first drugs administered in a patient whose heart has just stopped. Since I did not have a costly machine to measure acid concentration, I did not know how much bicarbonate to give, so I just guessed, plugging hypothetical numbers into a memorized formula and arriving at the dosage. Bicarbonate rarely works because it does not address the cause of the shock, whether it be rampant infection or fluid loss. Nonetheless, I drew some up in a syringe in my usual non-sterile fashion that made visiting volunteer nurses cringe and injected it. For some reason, it worked. It was like Lazarus coming back from the dead. Within seconds, Chantal started to thrash around, screaming and kicking, upset that I had rudely interrupted her death. As with all children, her hand instinctively went to her head to pull out the disturbing needle sticking in her scalp. My hands instinctively stopped her, and 3 minutes later we had a howling, gyrating 2-year-old tied down in a barbaric but effective fashion. Guessing again at the dosage, I added bicarbonate to the normal saline solution, ensuring that she would receive a slow, constant infusion to maintain the proper acid concentration while her body slowly compensated. This is exactly what happened. Her feet and hands warmed up, tears welled up in her eyes, and her mother began chanting some prayer that I could not understand, but I am sure the sisters approved because it sounded Catholic. Her long-term care was more challenging. I never determined why she was in shock in spite of several spinal taps, multiple malaria checks, and microscopic examination of every secretion. She never had a fever. But in Haiti, this is not significant because the patients are so sick and malnourished that they cannot mount one. Just to be safe, I gave her a week of intravenous antibiotics. Chantal would not eat for 2 weeks, but managed to fight when I passed a nasogastric tube through her nose into her stomach. With it, she got her nutrition, and the protracted recuperative process began. First with her nibbling her food and then developing a hearty appetite. Her cheeks fattened, her belly grew, and she began to stand up and ambulate. Her brown skin turned ebony as the anemia corrected. Eventually, she started smiling, running around and playing with the toys. She especially enjoyed playing with the miniature plastic bricks, stacking them up and gleefully knocking them over. Her mother was so pleased she offered to give me Chantal as payment. Perhaps she also knew that when she took her Chantal home, her daughter would soon be sick again. The most pathetic patient in the children's home was a 4-year-old girl, Alice. When I first saw her, she had a well-demarcated rash on her face, arms, and upper legs. This disfigurement made her a pariah, forcing her to stand away from the other children to avoid their cruel teasing. I did not know what the rash was, but I assumed its cause was fungal and started treating her with an expired antifungal medicine. Not only did she not improve, she got worse. Bewildered, I had no alternate plan of therapy until a visiting dermatologist came to my rescue. Andrew Simone was prospering in his 6-figure private practice in Toronto when he discovered he was not happy. A short, roly-poly, balding man, he was of Italian descent and looked it. His bearded face and humble demeanor gave one the impression he was a monk rather than a physician. In his search for spiritual well-being, Andrew donated all his earthly possessions to the poor. He continued to work, but he gave his income to the poor too. He fed his wife and 9 children by asking for donations. Begging, he claimed, kept him humble and able to empathize with the poor. Many who met Andrew felt he was unhinged, but he was not. He just responded to the rat race in a productive manner rather than becoming an alcoholic or regressing to a second adolescence like so many others. There was one thing Andrew was, a crackerjack dermatologist. Harvard trained and gifted with a phenomenal memory, Andrew taught me the dermatology of blacks. I had tried to learn some of this subspecialty by reading on my own, but the civil rights movement has yet to make it to dermatology textbooks. The pictures are of Caucasians. With Andrew's help, I learned to diagnose leprosy, syphilis, sarcoidosis, tuberculosis, psoriasis, scabies, and eczema. But Alice baffled even Andrew. He had never seen anything like it. We tried antibiotics, vitamin creams, steroid creams, antifungal potions, and even holy water. Nothing worked. Poor Alice developed huge amorphous concretions around her eyelids and cheeks, a hideous raccoon-like mass that made her appear extraterrestrial. They spread down her back, arms to her hands, protruding from her fingernails like rhinoceros horns. These concretions cracked apart and bled, making them exquisitely painful. Alice's very existence was torture. She howled when anyone touched her, totally rejecting human warmth. The emotional scars were as devastating as the physical ones. I took every doctor who stopped at the children's home to see Alice. Nobody knew her diagnosis, but the cameras clicked. One day, the long-awaited phone call came. An oncologist from Texas showed the pictures of Alice to his colleagues, who concluded that a biopsy was needed to make the diagnosis. They offered to examine the biopsy and send the necessary medicine free of charge. I hung up the phone, finished the most urgent work, and then hopped on my moped, shopping from pharmacy to pharmacy for 2 hours until finding one that carried the preservative formalin. Returning to the children's home, I found the instruments needed to perform a biopsy. Alice always had the same reaction to my presence, unadulterated terror, since I often caused pain by applying my latest ineffective potion. This was even worse. I anesthetized her right forearm and excised an ample piece of pathological tissue and placed it in the formalin. The next day, it was on its way to Texas. 1 month later, another doctor arrived from Texas with the diagnosis: mucocutaneous candidiasis, a fungal infection. I had never heard of this entity, but the doctor was kind enough to bring several journal articles too, and these I quickly devoured. More important, he gave me a powerful but expensive antifungal drug to administer to Alice twice a day. Each pill cost $2. But it worked. The concretions dried up and fell, leaving a mild rash. Alice began to smile and play with the other children. She even allowed me to hold her, although she always eyed me suspiciously. Between the deaths and patients like Alice and Chantel, my moods swung from depression to euphoria. Rarely I experienced anything in between. The sickness of a child is grossly unfair. Even the most hardened of individuals cannot stand to see a child suffer. An ill adult understands what illness is, but all a child comprehends is its miserable state. A child will cry, refuse to eat, and ignore human warmth. It was in the children's home that I learned it is truly the children who suffer.